So on behalf of Suchil, I really want to thank the organizers for putting tricuspid regurg so much in the forefront here of the programming. I really, this is a really new field for all of us, and we're learning so much from each other. The talk, again, was is residual TR grade an appropriate therapeutic goal? And so should it, again, be used as a primary endpoint, for instance, in clinical trials? And the basic premise of transcatheter valve therapy development is that many of the devices will mimic an established surgical therapy, and that therapy should demonstrate benefit, either lower or equivalent mortality to a comparative gold standard, which is presumably surgery in many cases. But in this particular case, the tricuspid, there are so few class 1 indications for surgical intervention on the tricuspid valve. And for functional tricuspid regurgitation, there's really only one, which is at the time of left heart surgery. That it leaves us in these tricuspid trials with a conundrum of what to use as a comparator. Obviously, also for endpoints, you want to look at hard endpoints. We all want to see mortality benefit, reduction in stroke, reduction in hospitalizations. But there are softer endpoints for the tricuspid patients, since we've all now witnessed that a single grade reduction in TR will benefit patients in quality of life metrics and 6-minute walk test, and certainly in the efficacy of TR reduction. But mortality and stroke are easy to measure. And the real problem is that, can we actually measure accurately the softer endpoints of functional improvement and tricuspid regurgitation reduction? And I think that's a real issue for these trials. Challenges with the hard endpoints, obviously the natural history of tricuspid regurg, not particularly well defined. Obviously a lot of seminal work coming out of Mayo. And I'll show you one of the studies that was just published apparently 2 days ago. The majority of TR is secondary, so that there's an underlying disease process that may drive the event rates as well. So again, similar to mitral regurgitation, are you dying with TR, or are you dying because of TR? And then the competing risks in the elderly patients may mask the benefits, and then longer-term follow-up may be required because the mortality curves do not drop off precipitously as they did in the aortic stenosis patients. What matters to patients, though, it turns out, really is the quality of life. So studies in advanced heart failure have shown that 25% of patients would trade off days of life for quality of life, and that examples of approved and reimbursed therapies with no effect on mortality but improvement in functional metrics of 6-minute walk tests or quality of life have been approved. And so TR grade, however, which is the question of this talk, is not actually on the list of outcomes that patients care about. So why choose TR reduction as an endpoint? Well, what you're looking for in an endpoint is a quantifiable, objective endpoint that allows for evaluation of changes within individual patient. It allows for assessment of serial changes and the durability of the results, and frankly, to be able to compare between various devices. And then you want TR reduction to correlate with clinical outcomes. And the diagnostic challenges of tricuspid regurgitation, as you already have heard in a number of talks, is extraordinary. Regurgitation is dynamic, volume dependent. Volume overload is tolerated for many years, unlike pressure overload, and so the patients come to us with very extensive regurgitant volumes. And there's a poor understanding about the grading of severity on echo. And you've all seen the guidelines before and the grading scheme of mild, moderate, and severe. But just as on the mitral regurgitation side, when you have a list of variables to measure for severity this long, then you know that there's no good metric that we have, no consistency necessarily in any of the measures. Obviously, it's a multi-parametric, multi-view analysis, and we know also that the proximal ice velocity surface area method, which has been advocated by our guidelines, does not actually, the assumptions of that method are not fulfilled by tricuspid regurgitation. And those assumptions include that the regurgitant orifice is in a flat surface, that there's a circular orifice, and this is a classic example of tricuspid regurgitation between the septal and the anterior leaflets with this long crescent-shaped or elliptical orifice. It assumes, PISA assumes, because it assumes a circular, it assumes a hemispheric proximal flow convergence, and this is just a biplane image using the baseline shift to show you that you've got one narrow PISA and one very wide PISA. And so this is a hemi-ellipse, which some investigators have actually corrected for. And then finally, we measure PISA typically with a single point in time, and we know that these jets are varying, time varying. We developed this, this particular scheme in order to proceed with the trials of transcatheter devices, because what we were seeing were patients coming in with severe ×4. So in the former trial, as you saw, and I'll show you again some of the baseline measures of regurgitant severity, regurgitant orifice areas could actually be measured at more than 4 centimeters squared. And those just can't be described by just calling it severe. You can have a 2-grade reduction from torrential to severe, and without this extended grading scheme, would we actually be showing any efficacy? And it turns out that we probably are. The Santoro article that just came out looked at the outcomes, natural history outcomes, using severe versus massive and torrential. It did lump together the massive and torrentials, which is what was advocated by the European guidelines, and showed that there was a significant mortality difference between severe and massive or torrential. So now we know that there is indeed a difference in the degrees of severity of regurgitation. We also have a problem because the transcatheter solutions at this point are numerous. We have any number of annuloplasty devices being developed, both direct and indirect, coaptation devices, heterotopic and orthotopic valve replacement devices, and all of these therapies approach regurgitation in a different way, making the uniform assessment of TR challenging, and particularly to be consistent between devices. If you have devices that alter the annulus alone, then we still can use many of our standard measures and the ones that we've been exploring, such as not only PISA, but quantitative Doppler and 3-dimensional vena contracta area to assess the regurgitant orifice in the middle. But once you have devices in the middle of the orifice that have clipped the leaflet tips or grasped the tips or put a spacer in between, now all of a sudden you've lost frankly all of the standard ways of measuring regurgitation. And what we have found, and this is one of our forma cases, is that using 3-dimensional vena contracta area and then averaging the vena contracta area planimetered over the entire systolic time interval is what may be indeed the answer to our problems. You can use it for the forma device. This is us using it again for the mitral clip device, off-label use on the tricuspid side, and the vena contracta area, pre and post device, may be one of the more robust ways of determining severity. That's already been shown on the mitral side. So this is a new study by Eleonora Avenatti, who is also working in our core lab, but did this through Houston Methodist and looked at the value of 3D vena contracta area for assessing severity and outcomes associated with the mitral clip. And so we do believe, again, that 3D, we will have methods, but they need validation. And for TR reduction, there has to be a meaningful endpoint that needs to be correlated with clinical outcomes. And do we have enough evidence that the actual degree of or severity of tricuspid regurgitation is associated with outcomes? Well, it turns out, again, much of the work has been done out of the Mayo Clinic, and Maurice, I think, is sitting in the back. This is one of their studies headed by Jan Topilsky that showed that using the PISA method for quantitation of the EROA, effective regurgitant orifice area, that 40 millimeters squared actually is bad. And so there's a worse outcome in those patients with 40 millimeters squared versus less than 40. And then the newest data, which Maurice just gave to me, comes out of circulation just a couple days ago, showing again in a patient population where now they've controlled for some of the comorbidities that are seen, but in this particular case, ejection fraction, and shown that the severity of regurgitation is in a graded fashion associated with mortality. Whether or not there is RV dysfunction, pulmonary hypertension, or not, you can see a significant graded response to outcomes. So we do believe there is data that suggests that tricuspid regurgitation in and of itself is associated with outcomes. Now, we also know and believe that even after transcatheter devices on the left side, similar to outcomes with surgical mitral valve surgery, that if you leave a lot of tricuspid regurgitation or have baseline severe tricuspid regurg, you will also have a poor outcome. But what we know also is that failed repairs don't help the situation. Obviously, this study showing again that in patients undergoing left-sided surgery with tricuspid repair, there's a significantly worse late outcome with residual tricuspid regurgitation, and that again, the K procedure, which is a suture repair, did significantly worse than an annuloplasty ring. Residual TR is a bad thing, and so we know also that our device therapies have to answer to these surgical outcomes as well. And when you look, predict procedural outcomes in the patients with edge-to-edge repair, we can see that if you have a successful repair, and now this is a relatively low bar of only 1 grade reduction in tricuspid regurg, you still see a mortality benefit. And so it's not that we have to get to 0. We can reduce it by a single grade and still have improvement in outcomes. But again, is that enough for our patients, and do we need to actually do better than a single grade reduction? It turns out Dr. Hausleiter reported this in a late-breaking trial at TCT in 2018 that showed that defining the success, that if you have a successful edge-to-edge repair on the tricuspid side, that not only do you have an significant improvement in functional status, but you also improve mortality. So now a couple different studies showing again that we can indeed change the outcomes of our patients by even a single 1 or 2 grade reduction in tricuspid regurgitation. But remember the FORMA study. This is where 80% of the patients had torrential tricuspid regurgitation. And so is treating torrential tricuspid regurgitation still of benefit? And I think you saw Macaleed's presentation of the results. Functional status definitely improves. And so we still are waiting for long-term outcomes and hard outcomes with our device therapy. So the final thoughts, despite challenges in assessment, reduction in TR should be an endpoint, because it has to be an endpoint to show efficacy. However, at this particular time, because we are not sure how to measure it, every device is a different measure, at this point, I think TR should remain a secondary endpoint with the use of functional data as the primary endpoint. And that can include re-hospitalization as well. Criteria for success in early stage trials should be a safe implantation. TR reduction and how much of that needs to be reduced is up for discussion. And then improvement in quality of life or functional status. Thanks for your attention.
Becky, that was great. Thank you very much. And please, we've got plenty of time, so if people have questions in between the talks, feel free to indicate. We're happy to entertain them. I'm curious, so if you think TR assessment by echo should be a secondary endpoint, at the end of the day, all the other things we do affect functional outcomes too, and these patients have so many complicating things. I still worry about hanging our hat on a functional endpoint. I liked what you said earlier in your talk about having a metric more or less to hang your hat on. Or do we need something that's not functional, not echo, like a BNP or endocrine type measure, some other metric other than what we've all been talking about?
Well, I mean, I'd love another metric. I don't think that BNP, we've seen in some of the trials, the early SCOUT trial, for instance, didn't show a huge, even though tremendous 50% reduction in EROA and tremendous significant improvement in not only cardiac output but functional status, didn't show a huge change in BNP. We couldn't find a change in BNP. So I don't think BNP is a good marker on the right side. If we never looked at gamma GTP, which we can do, or maybe this liver stiffness for hepatic congestion. If we can find a measure of renal perfusion, that would be fantastic as well. But not even the COAP trial used MR reduction as a primary endpoint. So I just don't think that if the COAP trial didn't use MR as a primary endpoint, that our tricuspid trials need to answer to a higher calling. I think that we should keep it as a secondary endpoint and use other metrics for a primary.
We struggled that in the design of Triluminate Pivotal. We had a lot, because we originally wanted TR reduction to be in the primary endpoint, but then there was so much uncertainty about the ability to quantitate it, and also uncertainty about, well, is moderate enough, or do we need to get better than moderate? And because of that, I think everyone felt it was more apt to move it to a secondary endpoint for all those reasons.
So first, Becky, we struggle on the mitral side about trying to evaluate the severity of MR. In terms of TR, I mean, we now have this elegant classification scheme that gives us now 5 classes and takes us to severe and now 2 classes beyond. Are echocardiographers generally equipped to be able to accurately diagnose the degrees of severity of TR? And should we leave it as a descriptive 5-grade system, or are quantitative indices required in order to make these subtle distinctions about a TR improvement?
Yeah, that's such a good question. I mean, I do believe at this point echocardiographers are not grading tricuspid regurg correctly. So there needs to be a massive education endeavor by device companies, by societies, everybody, to try and re-educate the thinking about tricuspid regurgitation. And we've attempted to do that with new guidelines that have been put forth, and we'll continue to do that with the research. But I do think that because it is so difficult and so variable, that we are also looking for more, programs that may do some of this measurements, automated. And I think artificial intelligence may help us, design some of these programs that will be able to help the clinician.
So I kind of agree with you that TR reduction should be an endpoint. I certainly don't think it should be part of a primary endpoint. So I think a secondary endpoint and even a powered secondary endpoint. Because if you're developing a TR reduction device, and if you can't show that there's an objective reduction in TR over a period of time, then I have to argue that I'm confused about.
Yeah. No, you're right.
That being said, in pivotal, it's not powered. It's counted as endpoint. But we didn't power for that endpoint. So, I mean, we have an expectation that, based on the EFS data, that 50% will get to moderate or more, 50%, around 50 to 60%, but there's just too much uncertainty. And also with some changes in the device that have been made too that are new for the pivotal trial, there's hopeful we'll beat that, but there was just too much uncertainty to power it. So,
I think one of the challenges is we've also tried to convince the community around us to send us your TR patients, is even though we reduce their TR a little bit from torrential to massive, and the subset of those patients actually do better, sending them back to their referring cardiologist with still now massive TR, it means we're probably not getting another one out of that referral line. So I don't know how to handle that one yet.
Well, I'm hoping that they'll see that the patients feel better because, so many of these patients with a single grade reduction, I mean, we showed it in the early feasibility trial for Triluminate, 1 grade reduction, whether it was torrential to massive, massive to severe, severe to moderate, and obviously more than that, like a 2 grade reduction. All the patients improved their functional and quality of life metrics.
and it was comparable. So whether you had residual moderate or residual severe, or even residual massive, as long as you went 1 grade down, the KCCQ improvement was 15 points for
And
each of
that's
those.
a lot.
Yeah.
A minimum of 5 points is a significant change for the patient.
Yeah.
Yeah, I agree. I'm not suggesting that you need to achieve a certain objective threshold for 2+ or less, but I think the ability to be able to show some reduction in TR and the association with reduction in TR and other clinical benefit endpoints, I think to me is the association that you're looking for. And that's already been suggested, certainly, in many of the EFS studies and the other extended feasibility studies around the world. So even though this is a component of what we measure, it's an area of great confusion for most people. And it's going to be interesting in the TR trials to see what level of reduction does correlate with what degree of clinical benefit.
Is there going to be a TVARC like there is MVARC? Are we going to see that sometime?
Well, we keep talking about that, but, and I'll mention it in my next talk, We tried to initiate an effort to get us along that road 2 years ago, and I have to say, we haven't learned very much in the last 2 years. And there's so much uncertainty that I'm not sure that we could establish the kinds of criteria. There have been very few randomized trials. There's much less in the way of surgical data. We don't have very much in terms of natural history. We can come up with consensus documents, and we can come up with guidelines for how to define specific endpoints, but it's not going to have anything close to the level of robustness that we saw with VARC and with MVARC.
Yeah, that's right.
Well, all of this discussion, I think Marty sets you up very nicely to give us the real answer about what are going to be the compelling endpoints to change our practice with tricuspid valve disease.
Thank you, Scott. And I want to thank Paul and his team for setting up this meeting. Very impressive program, great faculty. I'm sorry that the weather has gotten in the way with some of the travel, but we will definitely push forward, and we'll do our best to see if we can fill in some of the gaps. So I've done my best to add some slides, which I'm usually pretty good at. And rather than applying my kinetic New York City speaking style, I'll pretend that I'm from Colorado or Minneapolis or Virginia, and I'll speak a little bit slower so we can consume some time. This was a very provocative question. What are the compelling endpoints for practice change? And I'm not sure that I can give you a simple answer, but I'll do my best. I was musing as I went through some of my older slides, and I looked at this session that we put together 2 years ago, and how we're still asking some of the same questions. And we have at Columbia, we have screened 250 TR patients, severe TR patients over the last 2 years. We've treated between 50 and 60 of them with new devices, and we are still learning. And we still go to clinic, and we see these complex patients, and we throw our hands up and say, we're not quite sure what to do. So I think this is still an interesting and very evolving area. It's exciting. I think we'll have some solutions, but I don't think that I can give you firm and definitive conclusions.